Good evening and welcome to Rodseth Christi South Africa, and welcome to our weekly interviews with various scholars from South Africa and also other countries where we tackle all kinds of questions. Who is Rodseth Christi? We are a student campus ministry based in South Africa, but obviously with originating out of the United States, where we have multiple chapters, universities in the US and all over the world. We are a campus ministry that focuses on helping Christians on campus to better understand the Christian faith, to be able to think about the reasons for their faith, and to be able to develop responses to the varieties of objections that often come in the university setting. What kinds of questions? You name it, basically. We deal with philosophical issues, scientific questions, historical questions, ethical questions, all related to Christianity and the big ideas and the worldviews around us. And so we're trying to equip Christians to be better prepared to understand their faith, and then on top of that, enable them to again go out and be more persuasive in sharing the gospel of Christ with others. We actually also have a website here in South Africa, rodsethchristi.co.za. Please feel free to visit that site, and we publish articles on a weekly basis, and you can go and check those out. We have other resources there available to you, so please do check out our website. And also, please do think about subscribing to our YouTube channel, where we also have a growing library of interviews and talks with people on all kinds of topics. You can find a lot of resources there and recommended sources as well, as we link to other Christian organizations and ministries with whom we agree on issues or just interesting stuff which we might not necessarily agree with, but we think will be useful in developing Christians to think carefully in this world. This evening we have a guest speaker who is also a scholar and an expert in the area of medicine, Professor Rodseth. He is a medical doctor based in UKZN. Professor Rodseth has did his medical training in South Africa, but also did research overseas in Canada, and has a pretty potent CV, if I could use that word. But I'm not going to waste time on elaborating all of that for you. He also conveniently happens to be part of our Rodseth Christi South Africa team, and together with Jonathan De Beer leads the Rodseth Christi chapter at UKZN, and he's married to Miranda, and they have 2 boys. And he's going to be our guest speaker this evening, and is going to be tackling arguably one of the most contentious issues of our age, the question of gender and identity. And so we have Reitze here this evening to tackle this potentially explosive topic. But as Christians, I think we need to have more Christians engaging on this critical issue of our age. And so this evening we do have somebody here in South Africa who I think is about as best equipped as you will find to help deal with this issue from a Christian perspective and from a medical perspective and a philosophical perspective as well. So good evening, Prof. Rodseth. How are you doing?
Good. Thanks, Simon. Thanks for the opportunity to chat to you guys.
Yes, my pleasure. And I hope we won't waste much time, but what we'll do is hand over to you. And I know you've got a lecture prepared for us, so if you can crack on with that. And then when we finish your talk, then we'll default to a Q&A time. I have a few questions I'd love to ask you, and then we'll take some questions from our audience off of YouTube, and I'll send those through to you as well. So the floor is yours. Away you can go.
Thanks very much. I'm going to dive straight in. Let me just share my screen. There we go. All right. You guys able to see everything that's going on there?
Yeah.
Great. So my name is Reitze Rodseth. I'm a professor at the University of KwaZulu-Natal. I'm currently working in private practice, and as Simon says, I've been involved with Rodseth Christi here in South Africa, often speaking on issues of medical ethics and sort of the overlap between Christianity and the biological questions that we face. My background is one of medicine. I studied medicine at the University of Pretoria. I also have a keen interest in minions, as you may see. I then studied anesthetics at the University of KwaZulu-Natal and specialized in critical care. Been working quite hard at the COVID pandemic at the moment. And up until about 4 or 5 years ago, I was head of Gray's Hospital as the head clinical unit. And it's through my interest in medicine, and particularly in the analysis of research and the quality of research, that I've got involved in many of these questions and these thoughts. So when I speak about these topics, I come at it from my research background. I've done a lot of work in anesthetics, and particularly in the valuation of the quality of research, how well the studies are designed, how well they're put together, what type of message they're conveying. And through that, a lot of, I'm sort of speaking from that background when I speak around the issues of gender identity. So as Simon has said, gender identity is probably one of the biggest and hottest topics, most contentious topics that we're facing at the moment. And so when we talk about this topic, I think you need to be sensitive and careful when we talk about it, and come at it with an issue of love. It's important, though, when we talk about love, is to define that concept carefully. And my understanding of one of the best definitions that I've seen of love is setting your will to seek the true good of the other. So when you set your will, you make a decision to follow through with something. It's a conscious decision that's made. It's not an emotional infatuation that comes and goes as you feel or not. And the next component of that is to seek the true good of the other person that you seek to love. And that concept of good, what is good, what leads to human thriving, what is good for us, is critical in understanding that. So with this background, I'm going to dive in. So if you've done biology in medical school, you'll have a little bit of an understanding of this. Biological beings are split into two groups, males and females, and this is linked to our reproductive functions. You have males and females, and when they reproduce, you get offspring, both male and female. Females genetically in humans have got two of the same chromosomes, the sex chromosomes. They're called X and X. And in men, it's an X and a Y chromosome. And based on that configuration of your sex chromosomes, you will then develop the sexual characteristics of either a male or a female. And we see that across the biological spectrum. The second important term that we work with is a term called intersex, and inter means between. And when you think about intersex, you end up looking at two broad categories. You can have genetic intersex or hormonal intersex. And I'm just going to drill down a little bit into those categories. And just as a preface around this, understanding these terminologies and the words that you're using are very important when you think about this and when you talk about it, because if you start to conflate or mix these terms up, you can end up at a lot of your communication with the people around you is going to be seriously impaired. So you want to be very careful about the terms that you're using, that you understand them, so that you can communicate clearly with people. So as I've now said, intersex is between sexes, and there's two broad categories of this, genetic and hormonal. As I've said, a male genetically is XY and a female is XX. In genetic intersex, there's a mutation or a problem at the chromosomal level. And we are able to put these mutations, these changes on the sex chromosomes have been given specific names, because they correlate with clinical pictures. People will present with certain signs and symptoms if they have this genetic abnormality. So Turner syndrome, there is no Y chromosome. It's called XO. And trisomy X, tri means 3. Trisomy X syndrome, you've got 3 X chromosomes and no Y chromosome. In Klinefelter syndrome, you've got 2 X's and 1 Y. These are at their basis or at the root a genetic abnormality. Just to come back, these are very well recognized clinical pictures. You can take a sample of DNA, analyze it, and identify this. And this is your genetic intersex. The second type of intersex that you get is hormonal intersex. And in these people, they have standard genetics. So they will be male XY or female XY. And the body starts to make the hormones that would then cause them to look male or female. There's a problem in either the way that those hormones are manufactured or the way that the receptors that are supposed to respond to those hormones are presented. And the sexual characteristics don't present properly. So you've got genetically males, XY, and the two abnormalities that are quite common is 5-alpha reductase deficiency or androgen insensitivity syndrome. So you don't make or you don't respond to testosterone, or you'll have a partial response to testosterone. Now, the interesting thing in the human body is if there is no testosterone or if there is no Y chromosome, the human will develop as a female. XX is the default setting in some ways. So what happens with these people is that they have got a male genetic makeup. They often have higher levels of circulating testosterone, and they have either incomplete or complete block of the function of that testosterone. And these are a lot of the people that are making a lot of news at the moment around the world, and particularly here in South Africa, because genetically they are XY, they're male. They have a lot of very strong masculine features, muscle strength, muscle bulk, bone bulk, higher levels of circulating testosterone, but they look female. And then as a result of that, they're often competing against biological females and outperform them quite significantly as a result of the advantage that the testosterone has given them. And we're in South Africa quite well aware of this as a result of the issues around Caster Semenya. All right, so we've spoken about sex and we've spoken about intersex, and there's two subcategories in those, genetic and hormonal intersex. And then we have another concept called gender. And gender is the concept of how you identify and present yourself to the world. So what is it to be male and what is it to be female? If it's male, do you wear your khaki plaid shirts and your big boots? What does it mean to be female? How do we dress? How do we act? What do we say? How do we do? It's a very interesting thing. And again, definitions and the meanings behind words become very important when we talk about the word gender. A lot of people will say that gender is a socially constructed concept. The society creates the concept of gender. And to a large degree, I agree with that. So the way that men are to behave, or the way that a man behaves in South Africa is different from the way that a man would behave in Kenya or in the USA or in Mexico. And even within countries, male behavior is supposed to play out in a slightly different way in different cultures. But what I've come to realize is that many people but when I say male or female, I believe that these roles emanate from your biological identity. You are XY. Boys are exposed to high levels of testosterone when they're in utero and when they're growing. As a result of that, they have particular behavioral characteristics. And this, as a result of that behavior, we associate a certain type of male behavior to this child. And although it varies in the cultures, the origin of this behavior stems from your biological sex. Many people don't believe this and believe that gender is something that is totally fluid. When they use the words gender as a social construct, they mean that gender has no link at all with biological sex. So it becomes important when you're using words to make sure that though you might be saying the same words, you might have very different meanings that underpin this. And one that I've really become to realize is this concept of gender. Okay. The next thing I want to talk about is transient gender dysphoria. Now, we've spoken about gender. This is the way that I identify myself and the way that I want to express my sexuality, my gender, my maleness or my femaleness. Dysphoria is the opposite of euphoria. Euphoria is a feeling of joy and happiness. Dysphoria is a feeling of discomfort, something creeping under your skin. And these people are unhappy and feel a severe degree of anxiety or discomfort with the gender that they are supposed to be fulfilling. So if I'm a boy, I don't like the idea that I'm supposed to be a boy. I want to be a girl. There's two types of this dysphoria. The first one is transient gender dysphoria. My emotions differ from my biological sex, but it is a transient event. It doesn't persist. This is very, very common. It happens in about 1% to 2% of children between 12, 13, 14 years of age. These children are going through a period of puberty. And interestingly enough, it's often young girls that are going through this process. So they're moving from a petite little girl into to becoming a mature sexual female, and they start growing breasts, and they feel they've got acne, and they feel a little bit clumsy, and they're not comfortable in their own skin. And a lot of that then gets expressed as I don't feel like a woman. I don't feel feminine. I don't feel like I'm supposed to feel like a woman. And so I wish I was a boy. I'm not comfortable as a woman. I'd like to express as a boy. The interesting thing is that 80 to 95% of these children will grow out of these feelings. It's transient. It doesn't persist. It's a normal characteristic of sexual development of children as they go through puberty. In contrast to this, you get persistent gender dysphoria. And this is a well-recognized psychological problem. It's the same concept. Here, my emotions, I feel female, or I want to be female. I'm not happy being a male, although I'm biologically male. And in these people, these feelings of discomfort, dysphoria, have persisted beyond puberty into adulthood. And interestingly enough, it's most common in men. It's very rare. It's 1 in 20,000 to 3 in 20,000. So it's a very rare incidence. Women, 1 in 50,000 to 1 in 30,000. And these people struggle intensely. They've got severe emotional anxiety and discomfort with their current sex, with their current gender. And it causes severe psychological trauma for them. It's really something difficult to cope with. It affects large components of their life. And a lot of these individuals will even go so far as to commit suicide as a result of the dysphoria that they're feeling. This is quite a serious psychological problem that needs to be taken very seriously. But I just want to again highlight the difference between persistent gender dysphoria and transient gender dysphoria. Transient gender dysphoria happening in teens going through their puberty. Vast majority grow out of it, often females, versus persistent gender dysphoria, adults, very rare, more common in men, very severe psychological impact. So what does it mean to be transgender? Trans means to switch or to cross over genders. And so you take drugs or you have surgery to change the way that you look on the outside to match what you feel on the inside. So I'm not happy with me being a male. I will then take testosterone blockers, or I'll take estrogen, and I'll start taking on feminine characteristics as a result of those hormones that I'm taking. And then I'll have surgery to make my body look like a woman. I'll have breast implants. I'll have surgical resection of my penis, remove my testicles, and so become a woman. And I'm then transgender. I've then crossed over my gender. So there are the terms: sex, intersex. Intersex has got two components to it: biological, hormonal, and genetic. The concept of gender. And the two aspects that we're going to be focusing on is gender dysphoria and this concept of being transgender. That's where the majority of this discussion is going to be lying. All right. Now, where a lot of the conflict currently in our society is happening is that this concept that what you think is what you are, or in other ways, you make your own reality, has taken on center stage in many people's mind. So what you think is what you are. If I think that I am a woman, if I feel like a woman, then I am a woman, and society must treat me as a woman. That concept is central to understanding where this whole argument is coming from, and why there's so much conflict around it. The principle is that you make your own reality. It doesn't really matter what my sexual, my chromosomal status is, what my genetic makeup is. If I want to be a woman, I can be a woman. If I want to be a man, I can be a man. So the concept is, and I want to sort of think it through, the implications of the statement. Basically, people are saying, if I think I'm a cat, then I am a cat. Or if I think I'm a dog, then I am a dog. Or if I think I'm a black woman, then I am a black woman. And as I look at those first three, I think you automatically go, whoa, that sounds a bit strange. But we're at a point in our society where I say, if I think I am a girl, then I am a girl, and you must treat me as a girl. But when we look at those first three components of it, we look and say, well, just because I think I'm a cat doesn't mean I have a tail and I have whiskers. Similarly, if I think I'm a dog, it doesn't mean that I go chasing after cats. And then quite interestingly as well, if I think I'm a black woman, I am a black woman. When you start to talk about race, people have very, very strong reactions when you try to cross over race. But in our society, we've got to the point where I say, if I think I'm a girl, then I am a girl. So this transgender ideology takes this thing to heart, and it says that this last point, I think that I am a girl, so I am a girl, is reality. By saying it, by thinking it, we then must treat you as a girl, and you are therefore a girl. So the ideology or the concept that underlies it is that what is foremost is how the person feels. And we must then bring about physical change, and often lasting physical change, to conform our bodies, your biological structure, your phenotype, the way you look, so that it matches with the way that you think. But I think this idea's got some serious issues with it. You've already seen some of what I think are contradictions or serious paradoxes that come in this. If we test this idea, one of the most powerful examples of the emptiness or the bankruptness of this idea is the concept of anorexia. Anorexia is a life-threatening disease, and people who suffer from it have an incredibly high mortality rate. And the problem here is that the person who is suffering from anorexia has a psychological belief that they are overweight, and they continue to starve themselves to lose weight. And every time they look in the mirror, they see themselves as overweight, as fat, and I'm ugly, I'm fat, I need to lose weight. So if we take the transgender ideology concept that you are what you think you are, then when the person stands in front of you and says, I am fat, and they look like this woman looks in this picture, then the right response is to say, no, yes, you are fat, and you need to continue dieting and losing weight. But clearly, there's a pathological, dysfunctional understanding of what this lady's body is looking like, what she thinks she looks like, doesn't correspond with reality. As I've said, there's a high mortality rate associated with anorexia because you actually starve yourself to the point of death. And the appropriate thing, the loving thing to do, is to say, no, your concept in your mind does not correspond with reality. We need to help you both physically and psychologically and get you out of this hole. There's another psychological disorder that I also think shines a light on this concept, or the bankruptness of this concept that you are what you think you are. This is called body integrity identity disorder. These people believe that their bodies need to have some type of dysmorphism or some type of problem. This woman believed from a young age that she needed to be blind. She had normal eyesight, but there was a disorder in her that saw this integrity of her body as being wrong. So she wanted to be blind. Approached multiple doctors to blind her, who then refused. And then finally she got somebody to agree to pouring acid into her eyes. And she's now blind. And when you look at that concept, I would argue that that just doesn't make sense. That the real problem here is that she has something in her mind that is causing her to inappropriately understand the reality that she's in. Similarly, there are patients that present to doctors saying that they want an amputated leg, they want healthy limbs amputated, because they believe that they need to be an amputee, or that their bodies shouldn't be a complete whole body. I want to take this idea even further. There's a generalized acceptance in many parts of our culture that you can transition your gender fluidly. If I want to be a woman or an asexual or no sexual, or then I can just say it and assume that position. But when we start talking about becoming transracial, then all of a sudden there's a big outcry against it. And this young white lady took on the persona of an African-American woman. And when she was finally found out to not be African-American, she was widely criticized, ostracized. But why, if you can transition your gender, why can you not transition your race? The logic follows. If it's true that reality follows the way that I think, then that must be true for race as well. So then I could say that I am a Zulu male, or a Zulu female, or an Asian woman. And because I believe it and because I say it, it's true. But that seems to be totally wrong. And in taking this idea to its most extreme, some people have adopted the concept of transspeciesism. So this gentleman believes that he is a dog, and the name of the dog is Boomer. He is Boomer, the dog, and he dresses in a costume, runs around in his where he stays at his home, eats food out of a bowl, lives in a dog kennel. And some people have taken this even further, believing that there are cats or dragons, and then transitioning transspeciesism, transitioning into becoming a cat or becoming a dragon. And again, I think this to a large degree shows the hollowness of the statement that what I think I am. Just doesn't make sense. Now, one of the underlying assumptions in this ideology is that if I change my body, it's going to make me feel better. I feel uncomfortable. I'm having severe dysphoria, unhappiness in myself because I'm a woman, and I want to be a man, and I believe that being a man will make me feel better. But is that actually true? Does it prevent suicide? Does it result in a reduction of the anxiety that people feel? And we've seen progressively more and more research coming out of this. Some of this is very contentious and highly contested. But as the data is coming through, we seem to see that doesn't result in this. It's not a panacea. It's not the answer that all of a sudden takes away all of your pain, all of your anxiety, all of your suffering. Just as I speak about this, I just want to emphasize that this research has been overwhelmingly conducted in patients with persistent gender dysphoria. So this is on sexually mature, generally men who wish to transition to becoming female, and not on pubescent children. So in patients who have undergone gender dysphoria, the suicide rate remains roughly the same as those who do suffer from gender dysphoria, which is in the region of 40% from the study. In a study out of Sweden, one study showed that the overall death rate in patients that had undergone sex reassignment surgery was higher than in those that didn't. Death from suicide was 19 times higher, increased suicide attempts, higher rate of psychiatric inpatient care, and then an increased risk of cancer and cardiovascular disease. And this is linked to the use of the hormones that you now need to take to maintain yourself. Again, this is sexually mature men often transitioning to become women. If I read this through, and I think this captures this quite nicely, persons with transsexualism after sex reassignment surgery have considerably higher risk for mortality, suicidal behavior, and psychiatric morbidity than the general population. Our findings suggest that sex reassignment, although alleviating gender dysphoria, may not suffice as treatment for transsexualism and should inspire improved psychiatric and somatic care. Transitioning surgically or hormonally is not a cure-all for this thing. A committee under the Obama establishment, when he was in the White House, looked at this from the national Medicare side and looked, is there enough evidence for them to present this as a treatment option? And their assessment of the evidence was that there was not enough evidence to determine whether gender reassignment surgery improves health outcomes for Medicare beneficiaries with gender dysphoria. Why? Because there's incomplete, inconsistent study results, poor quality studies, exploratory type studies, no controls, and no long-term follow-up. And again, this is on adults, sexually mature, generally men. The 4 best designed and conducted studies did not demonstrate clinically significant changes or differences in psychometric test results after gender reassignment surgery. In an article written in the British Medical Journal, and this article is particularly focusing on the use of gender reassignment surgery or transgender surgery and hormonal use in children, pubescent children. And it says that significant problems with how the evidence has been collected and analyzed prevents us from reaching definitive conclusions. Similar to puberty blockers, the evidence is limited by small sample size, retrospective methods, and loss of considerable numbers of patients in the follow-up and control groups. And many of the studies don't use control groups. So what they're saying here is that the evidence that underpins this whole movement is really, really bad. You wouldn't take a drug that had this type of evidence backing it. In fact, they say an archive of diseases in childhood letter referred to, this is GnRHA, hormonal treatment, as a momentous step in the dark. The development of these interventions should therefore occur in the context of research, and treatment for under 18 gender dysphoric children and adolescents remained largely experimental. And this is really, really critical. There's a lot of this, there is some research, not good research, about adults undergoing gender reassignment surgery and the use of hormonal therapies to transition. And that's not good evidence, but there's almost zero evidence in adolescents. And when we talk about these things, you'll see people taking from the gender dysphoria in adults, the permanent gender dysphoria, and trying to apply that to the children. And as this letter says, I think this is highly illegitimate. And their contention is that this is experimental. A large number of unanswered questions include the age at start, the reversibility, adverse events, long-term effects on mental health, quality of life, bone mineral density. We wonder whether the use of off-label drugs is appropriate because they can cause harm. We don't know what the long-term effects are. The current evidence base does not support informed decision-making and safe practice in children. One of the interesting things is that a lot of people, many people who undergo transitioning have dysphoria at the end and then have regret that they underwent it because they were hoping and putting a huge amount of hope in the fact that I would now be male and my feelings of dysphoria, my suffering will go away. But afterwards, when they look back at it, they say, I went through all of this surgery, all of this medication, and I still don't feel better at all. What are the regrets that people face? Well, infertility is one of the big ones. In women, mastectomies, that's often associated with neuropathic pain. Neuropathic means pain to the nerves, because when you do these resections, you cut nerves. Urinary incontinence, cancer risk, liver injury as a result of the hormones that you're taking. Coronary artery diseases, which are more common in men, so testosterone pushes up that risk. Blood clots and associated strokes that happen when you're taking things like estrogen. So these things are severe impact, have a severe impact on the body, and patients undergo significant change, and there is a cost, physical cost, that is associated with this. One of these persons who detransitioned, they write, I used transition as self-harm. It destroyed so many parts of my life. My seeking medical and social transition led to a deep spiral of depression and lack of identity, and was probably also caused by those things. Interesting, up to 60 to 70% of patients with gender dysphoria, they have associated psychological and psychiatric problems, severe depressions, mania, many people some substance abuse as well. And there is this, as this person has captured here, a lack of identity. I don't know who I am. I'm just dysphoric in who I am. And that is pushing me into trying to seek some type of resolution. And seeking that in the surgery and transitioning actually has made it worse. I've lost more and more of who I am. I was a train wreck waiting to happen, and transition fed the insecurities, anxiety, and hopelessness. So what we're seeing now in our society, particularly in the States, and now, unfortunately, I think starting to happen here in South Africa, is that there's been a surge in transgender activity among teenagers. And it's being driven firstly by this ideology of, or this truth, this lie, I think, is that you are what you think you are. So in our culture, you believe it and then you can become it. So if I believe that I'm a woman, then I can be a woman. And it targets particularly susceptible adolescents. And there's been quite a few articles written on the phenomenon of clusters, groups of young girls, adolescents, who want to transition to becoming male, in direct contrast to what we've been seeing historically, which has been adult males in a very low ratio, low numbers, wanting to transition to become female. We're now seeing huge or large clusters, 2 to 3 to 4 young girls who want to transition to becoming male. And a lot of that is driven by social media. It's all the rage. It's very cool. It's very interesting. It triggers a lot of self-validation, and you draw a lot of attention to it. And you're having these groups deciding that they are wanting to transition to become males. Very atypical, very new, something that we haven't seen before, and is causing a lot of concern under a lot of people. There's also been a lot of people have drawn attention to the fact that there are certain very vocal gender therapists who take on the role of being an activist, who push very strongly for the full acceptance of this idea. If you in any way express a degree of dysphoria at any stage in your development, you are transgender and you must undergo these things. And you really need to do this because you run the risk of suicide, and we need an intervention as quickly as possible. And the combination of all of these things is what's driving a lot of what we're seeing in the States, in the UK, and currently here. It's an interesting quote. This guy says, I really wanted to be a girl. Thank God the world of now wasn't then, because then I'd be on hormones and I'd be a woman. After I was 15, I never wanted to be a woman again. And that's my point when I talk about the difference between permanent and transient gender dysphoria. Here's the crux of the thing. Now, the problem, of course, is if you have a particular individual who wanted amputation or who wants to be blind, or wants to transition, how do you know that once you've done it, that they're going to be satisfied? Once you've blinded that person, they don't get their eyes back. After they've lost the leg, you can't regrow that leg. After you've undergone a mastectomy, you're going to carry those scars and the neurological damage from that potentially forever. All right, so let's just recap quickly. We've talked about intersex, and again, I just want to warn you when you talk about or think about these concepts, don't confuse intersex with gender dysphoria. People often, again, conflate these. Intersex is the genetic or hormonal side of the thing. Gender dysphoria is the way that I am presenting, how I wish to present my gender to the people around me. Gender dysphoria is split among persistent and transient. Persistent gender dysphoria, well understood, severe psychological disorder, causes severe, profound suffering in people. Need to work, a lot of work to be done. Gender dysphoria in pubescent children, this transient gender dysphoria, I believe, is part of, in many cases, in the vast majority of cases, part of the normal development of a child. It has now been taken and turned into something really, really, I think, quite scary. So, from a Christian perspective, the question is, how do we deal with this? What's lying at the root of this? What's going on with it? We are all broken individuals. None of us have it all figured out at all. And sometimes I think as we get older, we realize how broken we are. Our Christian faith says that once we realize that we are broken, we've tried to create our life in our own way, made a total hash of it, and we come to Jesus Christ. He takes us and he remakes us and he rebuilds us and makes in us a new identity, a new spirit. Kintsugi is a Japanese craft where they take a pottery bowl and break it and then rebuild it using gold as the material that holds it together, which makes it really beautiful pottery. The analogy is not 100% right for Christianity, but we as humans have this idea that we want to center our identity on something. We want to make our identity about our sex or about our sexual prowess. We build our identity around our money, our power, our position, our achievement. I'm a professor. I've published so many papers. That's what makes me important. This is who I am. But our identity, our value doesn't lie in the things that we have got, or our sexuality, or I am gay, or I'm heterosexual, or I'm married, or I'm not married. Our value lies in the fact that we are made in the image of God. And only when we have that at our center, at our core, are you going to find a degree of peace? Are you going to find the centering, the knowing who you are? And that lies at the core of many, many of these issues. Building our identity around things that are fixated in the world that we try to build around ourselves is a pathway to disaster. Stepping back and realizing that we are created in the image of God, that we have intrinsic worth, and realizing that worth in Jesus Christ, that's the key to this. Once we find our identity in Christ, this verse, I think, sums it up perfectly. 2 Corinthians 5:17, it says, therefore, if anyone is in Christ, he is a new creation. The old has gone and the new has come. When you have that at your center of your identity, that is who I am, that allows you a degree of freedom and a place to rest. And from there, you can start to work out into the rest of your life. What does it mean now that I am a new creation in Christ? Now that I'm a Christ follower, this is who I am. And that's it. Thank you, Simon.
Thanks very much, Reitze. Okay, well, thank you very much for helping us with that. I know that for many of us, one of the difficulties of this issue is that there are medical issues associated with it, and few of us have the medical knowledge required to navigate these things. And I think the the issue that you've certainly, I think you're driving at here, is that behind this development within society, we can see a profound influence of philosophy upon this issue. Would you say that that's a fair assessment?
I think so. It's a consequence of, as I've said here, a philosophical concept of idealism, that the world is created almost in some way by the ideas. What is really true is our ideas. So that which is in my mind creates the reality around us, or strongly influences it. And we can see it in the Disney songs that are sung to the kids, and what people say, if you believe it, you can achieve it. You just need to think positive thoughts and it will happen.
Yeah.
I think that's then linked with a lot of the postmodern thought, again, which denies an absolute point of reference. So biologically, I think that sex and gender are grounded in the reality of your DNA, of what you are.
Mm-hmm.
But once you start to reject those aspects of it, it starts to, you remove that anchoring point, and then there's really no end point to where you can end up. But I think when you start to push these statements, if you are what you think you are, and I think I'm a girl, so therefore I am a girl, well then, if I think that I'm a black woman, then I am a black woman. But when you say that, all of a sudden there's a huge outcry, and you are seen as appropriating culture. And so that is taboo, but this is acceptable. And I think it starts to expose the underlying bankruptness of that idea.
And I think
genetics count.
Yes, your example of the woman in the image there, that very striking image of the woman suffering from anorexia, is a good counterexample to show that it would be difficult to say she's okay, she's just doing fine. You don't need to be a medical doctor to look at that poor woman and go, there's a problem here. And so this is interesting to me now, because I think as I've been trying to my best to study this issue, what I find staggering is the extent to which this philosophy now has not only gripped other institutions in society. We see this philosophy. I think it's tied to critical theory, which drinks deeply from this philosophical skepticism, this idealism of which you speak. Now, historically, that is tied to German idealism coming through the line of Kant, through Hegel, and then onto the postmodernists, who basically adopt that epistemological framework, epistemological relativism, and this kind of perspectivalism. What's true for me is whatever I think is true. This is my perspective. This is how I see things. But I want to ask you, as somebody who's in the medical field, how has the medical world caved in to this idea? I mean, Judith Butler writes a book on gender performativity, and it seems like now the entire medical fraternity in the West has just capitulated to the works of this woman. Because when it comes to this issue, particularly with this issue of gender, where she makes these distinctions, it seems like her idea of, gender performativity is what everybody is using now within the academy. Not that teenagers would know who she is or whether they understand her ideas, but as I'm digging into this issue, somebody like her seems to be prominent in this conversation, and knowing a bit about philosophy, she is drinking deeply of this postmodern philosophy. But I'm just struck by the fact that the medical community is just kind of caved into this stuff. And so, as somebody who works within the medical world, what would you say to the medical world caving into this philosophy? It's epistemology, basically. That's what it is. It's not medicine. It's epistemology.
Okay, so let me just unpack a little bit of what you've said. For those that don't know, Judith Butler talks about what's the word? Performatism.
Performativity, yeah.
Yeah, so
gender
basically, she believes that gender is made almost on the fly. As we do things, we become that gender. The performance of the actions of a male in South Africa, as I do those things, that is what that gender is. And so she argues that there's no biological link to this at all. She's got quite a convoluted argument to say that basically we are trapped in a stereotypical relationship where men are supposed to act in one way and women are supposed to act in another way. And those provide a straitjacket that from the past, and there's just cultural structure, cultural behaviors. And she called on as an activist to break those, to cause gender disruption. And so a lot of her writings, as you've said, is quite influential in take your gender wherever you want, into whatever you want. So again, she's decoupled it from the biological reality. So I want to split this into two answers. First, I want to say, I think that when parents are faced with this issue, the background noise in the newspapers, on Facebook, there's a heightened awareness of the issues of transgender, gender dysphoria. So the average parent is aware of these things. And when their child starts to go through gender dysphoria as a teen, and they've heard that gender dysphoria is associated with a higher rate of suicide, there is a true anxiety in their hearts about what is going on. And is my child at risk of dying or committing suicide because they are unhappy? So they will approach the medical specialists, particularly now as a result of this background, with that in their heart. So they're not trying to push an ideology, the parents. I think the vast majority of them are actually coming out of a point of true concern for the child, going, what can we do to prevent my child from sustaining harm? And then they will then present to the medical fraternity. Now, I think the vast majority of clinicians, and I don't do psychiatry, I don't have expertise in psychiatry or in sexual studies or in this type of surgery. But from my colleagues and the guys around us, the vast majority of people are going to be looking at this going, we don't know if this stuff works. If you start to look at the literature that supports this and the number of voices that are coming out in opposition against it from a medical background, these statements from the guys that looked from Medicare and from now in the NHS, a statement has been made. The NHS doesn't provide gender reassignment surgery routinely. They've withdrawn that as a service. And that's because the evidence base doesn't support it. But there are proponents that believe very strongly in this. And again, I think it would be very wrong to see them as being malicious in any way in what they're trying to do. I think they really do believe that they are helping the children that are presenting to them. But the data that they are basing these things on, underpinned again or supported by the ideology, is creating this nexus of that we're currently seeing. This, it's like constellation. And then, there are other things around it. You can make academic careers out of being a forerunner on this. You can draw a lot of attention by being a strong proponent of this. Unfortunately, you can draw a whole lot of negative attention as well. And we've been involved in a case or two where there's been quite vicious attacks launched on the perspectives that I'm putting forward here, to the point where people are, being reported to health professionals councils and written up in the media and attempts to cut people out of their practice. So I think the vast majority of people haven't succumbed to this. Doctors haven't, but they won't speak up because of the risks associated with it, because you'll be vilified and torn to bits in the media and go through all this thing. And they might not feel competent or comfortable enough in it. And then those that do speak very loudly and very aggressively, and with the cultural sanction of of what we're seeing at the moment, this broad acceptance of critical race theory, or critical theory that underpins a lot of these things. So if you stand up against it, we're two white men, how can we speak about this at all? What basis do we have to speak about it at all? And so those
Who are
ideologies are
we?
taken.
Yeah. Who are we to dare challenge their lived experience? That's the way this works.
You know, in the end,
language.
if a transgender person came to the hospital, first thing I want to know is what is their genetic, well, not the first thing, I want to know what the genetic background is. Then I want to know what the hormones they are taking. Because the background and the hormones create the physical medical problem that I'm faced with. Whether they think they are male or female or trans-species, you know, when it comes down to it, the person, the physical being that is in front of me becomes important. It becomes central. Sex, not so much central, but the medication, the hormonal stuff that you're looking at becomes an integral part of that person. And no matter what they think, they are what they are sitting in front of you. And yeah, building an entire human being surgically or hormonally around what is potentially a transient feeling just sounds crazy. And that's what the research is saying. In fact, in the and it's also being done on really prepubescent children. In the UK, they've now there was a court ruling that said that a child under the age of, I can't remember if it's 16 or 18, doesn't have the emotional maturity to be able to make the decision as to which gender they can't, and they don't understand the consequences of making this decision to stop their puberty, to take hormonal blockers, to undergo surgery. And they are no longer allowed to give consent to that process. And parents are not allowed to give consent as proxy, because once the child moves through the age into maturity, into 18, their whole viewpoint is likely to change in 80 to 90% of the time. And now you've got a child that's sitting there that's undergone, they're infertile because they've had surgery or they've taken hormonal blockers. And there's been cases of these children now suing parents and the medical teams that have undertaken this type of surgery. Again, I think there are some people that are unscrupulous, but I think a lot of people are caught up in the desire to do good. And it's driven by this, I don't want to harm you, I want to affirm you. I'm going to go back to that statement of love. To really love somebody is to put your will to see the best, their good, to see their good, to see their thriving, to see their growth. What is best for the child that is going through this process? Is it to be started on what these guys term experimental medication, surgery, while this is potentially a transient thing that will go away? I feel that is the case. And, you know, the NHS and courts in the UK and the Medicare in the US agree with that. There's a coalition that's currently being formed by international doctors, particularly sexual experts, and some psychiatrists, psychologists that are pushing back very strongly against this thing, saying we need a lot more research around this before we dive into it, particularly with the young children.
Well, I see. Yes, this is the crisis, though. I as I look at and listen to yourself, and you share with me what these medical experts are doing, I fear that the game is you've been outmaneuvered here now. This is not an issue of medicine now. This is an issue of philosophy. I mean, if you're going to deal with this, it seems like you need to train some doctors in the area of a refutation of postmodern epistemology. I mean, you've got to go after Foucault and his concept of biopower, because this is where these folks are getting these, or Derrida and the use of language. You talk about defining their terms, and this crowd is saying, well, who are you to define the terms? And this is so far out the province of anything to do with medicine. And so it's kind of like, for me, just as I listen to you and I listen to the medical folks, I'm going, I'm not so sure that this is going to help you, because doing more science and giving them more facts is impervious to this epistemology. They, for example, this issue, it seems, is going to expand now, not just to this issue, but if you read the critical theorists, now you have fatism and ableism, and the medical world has also imposed upon us what is the exemplar of the body, and now you have body positivity is a new term that's being coined. And so this thing is just going to continue to break out into various other things, not on the basis of medicine, but on the basis of this basic philosophy stacked upon a lot of it upon French existentialism. And really, it seems that that's where the root of this is. Am I wrong in saying that? I mean, as much as we need to do the medicine and make the cases, because as you said before, there might well be a small minority of kids who do have dysphoria, but now we've got large bunch of little teenagers who've been persuaded by their friends because they've been listening, I don't know, to Katy Perry or whoever it is on social media, and now they're in your offices and demanding that they get puberty blockers. And I don't think that's so. I think, am I wrong? Is that a fair analysis of where it is? Then that's what I kind of see going on.
The problem with the postmodern critical theory thing is that first, you did this, it multiplies almost like a cancer. But when cancer multiplies to a point, it ends up killing the host. And when you have these ideas that don't correspond with reality, at some stage you will pay a price for it. A few years ago, there was two badly conducted studies, small studies, on the use of beta blockers. Beta blockers slow your heart down. And they use these beta blockers before surgery to try and prevent heart attacks after the surgery. And based on that data, it was made standard of care in the United States. Your hospital was penalized if you didn't give beta blockers before surgery. Then somebody did a big trial on it and actually showed that patients that got beta blockers died more often and had more strokes than those that didn't get beta blockers. And one analysis suggested that up to 30,000 people lost their lives as a result of this injunction given on the back of poor science. So this sounds great and everybody's pushing it until the children start suing parents and you start to see the consequences stacking up. So the reality reasserts itself. So this thing will continue to push, but at some point you're going to show that this actually causes harm. We'll be able to identify those with true permanent gender dysphoria, and maybe those guys might be an option to consider this. But I think that you can't give up on that. You shouldn't. This is a two-pronged process. You need that data because the data, the reality of it, it actually causes harm. This is what we're saying. That statement that is experimental, it's made by a reputable high-level scientist. I think there should be injunctions in South Africa against doing this type of stuff. It's not in a research context. We don't know what's going on with these things. Just applying this highly potent therapy to the children. But linked to that is the argument that you're making, is that there's a massive philosophical creature in the background that drives a huge amount of this.
Yeah.
But I also think that the consequences of that are self-destroying. I think it's going to eat itself, because if I can identify today as a woman, why can I not identify as a black woman? Now, if you start to look at medical, biological classification of race, you can find articles that argue that race as a concept is, as a biological concept is almost fictitious, that we make such a big thing about it, but there actually isn't data to support this. So what are you talking about when you say that if it's so easy biologically to shift race, if you lose your coding for melanin, then my color of my skin changes. So if I marry somebody else, what's my race? So why can't I transition on race? But it seems to be a taboo thing. When you start to push those things in the culture, I think it starts to become unsustainable. So we need people to argue it. We need people to I think we need philosophers, but we need popularizers of the stuff as well. People who can make the connection between the average Joe in the street, like myself, and, who's not highly skilled in philosophy at all. Somebody who can take the really intellectual stuff and process it down. I think you just start pointing out some of these ridiculous consequences of the statements that you're making, and it just shows itself to be self-refuting. It just doesn't make sense.
Yes. I this is of interest to me because, of course, so it seems it's a medical issue, but it's also, there's a major philosophical issue here which has to be dealt with. There's going to have to be some philosophers who come alongside medical doctors to make these arguments, it seems to me, and to expose the philosophy which is driving this stuff, and particularly with that crowd of people, this sudden surge of youngsters who just are saying, well, I'm this way because, you know, my friends in my little group say so. I've seen some alarming stuff on TikTok videos here in South Africa of young teenagers talking about and using these terms, and they have no idea what they're talking about. Yeah, they've got no medical knowledge. They certainly don't know anything about French philosophy, but they're using this terminology, and so they're self-identifying, and away you go. And I can see the looming storm on the horizon there. From a practical side of things now, what happens to medical doctors? Now you're in a hospital, somebody comes in who self-identifies, but if you treat them as they insist they be according to their identity, what's going to happen to medical doctors now? Like, suppose you start administering drugs to an individual who self-identifies, but you know that those drugs are going to harm them. What can doctors do now? I mean, it seems to me that there's going to be these, as you said, this thing is kind of going to crash and burn because if he applies certain drugs, it's might be bad for the patient, but he must now treat the patient as if that patient is the gender they decide that they are. What's going to happen in that scenario?
Yeah, it becomes tricky. I don't know if there are drugs that are that gender specific, but the diseases that a person might present with would be a consequence of the medication and drugs that they are taking. So, you know, when somebody comes to you and they can't breathe because they've got a clot in their lung, don't really care if they are, well, I don't know, I think at that point it comes down to the biological function of trying to correct what's going wrong. And to get that, you will want to know what is your biological gender, which is anchored in reality. What drug are you taking, which is anchored in reality? And those things will then determine the treatment. If you want me to call you by a different pronoun while I do that, that's fine. If you wanted to be pretending that you were a cat or a dog while I was doing that, that was fine. But I would want to know, did you eat a stone? You know, what did you put into your body? What is actually physically happening with you?
Yes.
Because those things are what treating. And that's also what the person is presenting for the surgery for.
Mm-hmm.
It's very mixed up.
Yes, it seems like we're living in a very confused world. The other thing as well, and I think this is where people are seeing the kind of absurdity of this philosophy, is of course in the area of sport now. Now, of course, Caster Semenya has been used as an example to justify, I think, a lot of things. And as you've kind of presented today, she has a specific medical condition. But we see this in the sports arena. What do you think is going to be the future of women's professional sport? Is it going to be a case of, you know, there'll be two divisions? There'll be really athletic men who are competing, and then there'll be second-rate men competing in women's sport. Do you think that women's competitive sport is at a real threat now? I know with laws being passed in the US and elsewhere now, we're seeing that it's not just people like Caster Semenya who have a specific medical condition, but there's lots more men who, because they self-identify now, are now competing in women athletics and handball and Australian rules football and all kind, basketball, volleyball. I've seen international athletes. So what do you think of that development? Because that's also tied to this now.
I think that's quite strongly tied to that. And it's the prototype has been the intersex, the hormonal intersex individuals that have been outperforming women because they look female, but they are XY and they're male chromosomes, and they have levels of testosterone that allow some growth or some muscle bulk. testosterone improves performance, particularly in short power stuff. Like, there's no doubt about it. And we know it does it because they banned the use of testosterone in Ben Johnson racing in the hundreds. Those guys were all using testosterone. It improved them. They ran incredible times. It's illegal because it's performance enhancing. Now you've got a person that looks female but is running around with circulating levels of testosterone significantly 3-4 standard deviations above what a normal woman has. And so they run better. Now, when Caster Semenya took testosterone blockers, her time in the 800 dropped significantly. So I think it's unequivocal that if you're going to, there needs to be if you don't have some type of demarcation between male and female, then the categories become meaningless. Then you may as well just lump them all together. So where you draw the line is often arbitrary, but you need to draw a line. Otherwise, those two categories don't make sense. And there is I've actually recently, 2 days ago, watched an interview of two transgender men. They've transitioned to female and are competing in the sport, and then asking them, how do you feel about not being able to participate? And the whole tone of the discussion was around how isolated and rejected they felt. But there was no discussion because they couldn't compete as women. But there was no discussion about the reality of the fact that they are running with a muscular, the male physiology and a male anatomy that has been developed through the testosterone. And there was no discussion about what about every other XX woman that has been training their butt off, and all of a sudden one of these persons comes in with this high testosterone level and smashes them into the ground. So it was still very much an emotional discussion that was driving it. And if you look at what's happened with Caster Semenya, she's gone through multiple courts of appeal to try and get a right to run without using the testosterone. But the principle has been laid that the courts are pushing through is that you need a demarcation between these two groups. You need a line.
Yes.
If you don't hold that line, then you basically lose it. So do you create a third category of transgender? So you must have X, Y, and then you must be taking certain levels of estrogen to try and suppress your levels. And what happens if you have women who are male who feel that they want to create, you can start multiplying this ad infinitum. It again is very contentious, but I think it's pretty clear that you have to draw this line. It's one point, one or the other.
Yes, I mean, that seems what the same people to do, but it seems like with various politicians who are more interested or important to the philosophy that they're seeking to pass laws now, which is going to have ramifications on female athletes now. I mean, we've seen Martina Navratilova, getting cancelled because she said, look, this is going to be a problem because we're going to have some guy who's ranked 400th in the world in tennis is going to wipe the floor with Serena Williams, and he can just identify, and then off he goes. He's going to become the next women's Wimbledon champion, and I think she understands that, and I agree with her on that issue. And so it's interesting to see how this thing is cascading out in all areas of life. Not just that, we've seen this discussion spill over into the issue and the use of bathrooms, and that's tied to this as well. So this issue is affecting everything, diversity and equity training within operations and that as well. I do have some questions here for you that I do want to ask from our audience this evening. The first one is directed towards Christians. The question is this: many evangelical thinkers warn against Christians becoming useful tools in the politicization of moral issues like this. In that light, are Christians giving this issue too much air?
So I don't think so. I think, if anything, we're not stepping into the discussion lucidly and carefully. we are called to be light, to be salt and to be light in this world. And part of that is engaging with the world around us in our day-to-day activity. I think it is naive to believe that Christianity must somehow withdraw out of the political realm. I don't believe that Christian parties should be, so to speak, contesting elections. I don't think it should be a Christian party. I think there should be a separation between church and state. But Christians should be actively participating in community consultations. There should be an active voice in writing letters in the newspapers. They should be actively voting for parties and people who support and underpin Christian and good moral values. So I don't think at all. I think, and again, I think part of the problem is that we're not giving it enough air. We are not actually making an imprint at all.
Mm-hmm.
What we continuously see is the one side of the story. And when a Christian, somebody does speak on it, they are being vilified, attacked. So if this is going to end up on the internet, there's going to be an article written in a week's time, and then they'll submit it to the University of KwaZulu-Natal, and then they'll try and take away an affiliation or get you fired from your job or write a letter to the HPCSA or, so where's the counter voice to that? And if we don't step up and speak, it's the children that are undergoing and the families that are undergoing the real trauma, the difficulties, who then become easy targets for this. So I think we need to be stepping up more.
Yes, and I know that here in South Africa, I think what has got the attention of at least some parents is the issue of how this stuff comes in through various channels. We've seen this with the comprehensive sexuality education program, in which, of course, it doesn't give a massive treatment on this issue, but packed in there is that little statement that sex is a social construct, which of course is right out of the manuals of critical theory and their views on sexuality, and that's neatly packaged into that program, which some schools, I believe, are running out in the Western Cape. And so I think that, if Christians go silent on this issue, then you're not immune from these things. If these ideas are coming into society, and certainly they're very prevalent at our universities. In fact, they are, I would say, in many places dominant at our universities. And through the universities, the ideas come, and every other institution is going to be affected ultimately by the universities. In terms of which institution influences everything else, it's predominantly the universities. This is where critical theory and these ideas have come out of. They came from people like Peggy McIntosh and Judith Butler and Kimberly Crenshaw's ideas of intersectionality. That's the crowd of intellectuals behind the critical race theory. And these things are now part and parcel of all these institutions in society. And so I agree with you that as Christians, we certainly can't be silent. Your kids at the universities aren't going to have a choice. They're going to get dragged into this battle, whether they like it or not. I mean, even now we're seeing part of the slogans, silence is violence. So that's the demand being made now. I mean, if you're not seen to be bending your knee or speaking out against these things, then you're opposed to us. So I don't think we're in a position where we have that alternative to divorce ourselves from these things. But I do think, though, that we need to be more informed and engage ourselves on these issues. Another question here that I have from us is, what is the problem with thinking that it is reasonable to treat someone that they want to be treated, especially if it does not harm others?
So I don't have an issue in treating somebody the way that they want to be treated. I mean, that's fine. I think maybe I'm going to read into the question that's talking about this issue of pronouns. If I want you to refer to me as he, as she, or she as he, that the person that I'm having the conversation with must then use the pronoun of the person's choice. There's a few things around that. The first thing to say is that if I was requested to do that, I think I would probably start using the person's first name. because you are not your sexuality. You are who you are. You're a person. And so I wouldn't be calling you he or she, or I'd be using you as Simon. Then the second thing, if it was really that important, I would talk to them in a way that they wanted. I think we are to show love and compassion to the people around us and speak the truth in love. And when I say love, I mean that definition that I've used is setting your will to the good of the other. What I have a problem with is, and this is where Jordan Peterson came to fame, is when the government attempted to legislate and force language use. And that becomes a really dangerous stepping stone. And there's a big pushback against that. I think that's he saw in that the totalitarian overtones of what happened in Germany and in communist Russia. So that becomes a dangerous thing. And you've said one of these things that we're seeing now is it's not enough just to not say anything. You must stand up and agree with that which is being presented to you. So it's not just enough to be, it's not enough to not be against transgender issues. You must be for them. And if you're not for them, you're against us. And that becomes an issue. So in a one-on-one engagement, when somebody said to me, look, please refer to me as so-and-so, I think in that scenario, I don't see a problem with us doing it. But again, I'll probably start referring to them by their name, and that might lead as a Christian to a very interesting discussion about identity and open up a door for us to have a more profound conversation. But you'll only be able to have that conversation with the person if you treat them with respect. And through all of this, and I don't know if it's come across, but people struggle with these concepts. People are undergoing dysphoria. It's not just that I don't feel great. They have profound discomfort, particularly in adults, and it needs to be taken really seriously and treated with care and compassion. But I think it also needs to be treated with truth.
Yes, and so of course this is the challenge then, because I think that this is the difficulty for somebody like myself, because suppose I meet somebody who, for example, is in that predicament and needs serious medical advice and counsel from people like yourself and those with whom you work. That's one kind of person. But in some instances, I might just be dealing with some teenagers who've bought into some rank philosophy and French existentialism and just are convinced of that. And maybe that's the case. I mean, this is the difficulty now, is to know where that since we work at the universities, I'm not convinced that everybody who's identifying that is really having those struggles. And so I'd have to be careful not asking the questions now. What makes you think that? Is this something that you're struggling with internally, or is it because you're convinced that, in some sense, that what I think is what I am, and reality ought to conform to that? This is the difficulty now for us as we engage with people, because the philosophy is, it bleeds across into that, and it's hard to know when there's a real person who, as you said, there are people who medically we've known for decades, and we've worked with them. You guys have worked with them, and distinguish that from the crowd who are kind of just swallowing the philosophy of the age, which is also, I think, a large proportion of this as well. Difficult to know how to approach people on that. Do you have any advice for us on that score?
I don't know. I think it's sad that the people that really are struggling are going to, in some ways, be swamped and lose, maybe strange, but the attention that they deserve. It is harmful for the process. I think it's pretty easy, but I think you pretty quickly figure out what that person was trying to do, and what the type of engagement is. Working with students, somebody that's trying to, they will be speaking from an intellectual level. I've taken on this thing and I can switch my gender, but there is a sense of of real true suffering, and there will
Yeah.
be true suffering in those that are really struggling with permanent gender dysphoria. While some of the others might be adopting it as part of, as you said, the time of the age, and because of the uniqueness and the interestingness and the coolness of it in some ways.
Yeah, that's the difficulty, is the people who are really suffering then just become tools for this. And one of the questions here is somewhat related to it, because it says, can some of these cases involve parents and guardians encouraging / pushing children, teens down this path because of their own agendas? I mean, I was just listening to some of Ryan Anderson's work recently, and he was saying that some parents start grooming their children from as early as 3 if they start to, what is the term he used now, show or exhibit discordant behavior. And you've got clinics in America now that have got criteria which they give to parents who kind of are watching how their kids behave. And if they start as early as 3 exhibiting this behavior, then you've got to start grooming them, getting them ready for their teen years. And then when puberty comes on, then you start speaking to the consultants, and then you start thinking about puberty blockers and that kind of stuff, so that their body doesn't, if the girl is starting to get shape on her chest, you want to stop that. And so this is beginning in a very young age now. Do you think that in some sense there's those cases as well, that it's the parents who might well be forcing this upon the kids?
So I think all of our decisions, all of us are driven by multiple factors. We are driven by what we consider important or core values, and we're driven by our ideological beliefs. So I will raise my children in a specific way because of that which I believe to be true. I think you must be very careful to read malevolence into the action of parents. Don't ascribe the actions to them trying to hurt their children or trying to push an abstract agenda. I think those that are, if you believe the ideology fully and strongly, they believe what they are doing for the children is beneficial for the child. And so they are pushing this stuff to them because they think that this is the right way for the child to develop. It might be a small minority. I don't know what the percentage we are trying to make some type of statement or push some type of thing. But the parents, by and large, are focused on the optimal development and growth of the children. So they have swallowed the pill fully and believe that this is the way you should raise children now.
Yes.
So, yeah.
Yeah, I mean, we hear about this summit then. And maybe what we can do, because I know we've gone quite long here for a Q&A session, but like I said to you, this is such a big issue in our culture. But maybe we can close with this final question, Jan, just to see what you think about it. Is, what does the future of the church look like if we embrace these ideas in the church? And we see the reason I think it's such a great question is because we're seeing a lot of institutions and churches caving in to social justice ideas, which was undergirded by critical theory. We see this with the Southern Baptists, for example, in the United States. We see this with campus ministries, varieties of them, Campus Crusade, I think. We see this with universities, typically where you wouldn't see a problem. Biola University, for example, has been having issues with critical theory and social justice. And churches also are buying into this. So what do you think then? Should the church embrace some of this stuff and love people, or what do you think about this in the church?
So I think the church should love people using the definition that I have given. It's to set our will to achieve the good of those around us, of the other. And the good is that which is defined by God. What is good for a human being? What is a human being that made in the image of God? And what is good for that human being? And the most important thing that human being can achieve or know is Jesus Christ. And flowing from that comes the issues of who am I, the identity, the gender. You look at social justice, the word, again, these are definitions or what these things mean. The social justice espoused through critical theory is not biblical justice. It's critical theory is a zero-sum game in which there's always this one winner and losers, and a never-ending procession of intersectionality and oppression and anger, and it never ends, and there's no real forgiveness in it, and there's no sacrifice in it. In biblical Christianity, true Christianity, God's justice is transcendent on that, treats each individual as an individual, part of a society, but as an individual before God created in his image. So I think when you start to swallow those, in some ways you've lost the core. You are swallowing those because you've lost the mooring or centrality in your Christian faith. You've moved away from these core principles of who we are, who is God, what is our relationship to him. And you start to abandon those for the sake of social justice. And then what happens is that the church starts to become like the society, but it becomes like the society 5 to 10 years later after the society. So it looks old and outdated. Instead of standing in one point fixed on Christ as an independent, separate entity that's living counterculturally. So if things continue down this route, the true church should be progressively more and more isolated and more different, and looking a lot like we saw in the first century.
Yes.
Not very popular.
Very popular, yes. Yes, and I think that's a big issue, is the popularity is going to get to folks that want to remain, they like to have crowds coming. We like to appeal. We don't want to get too controversial. And look, this subject is really controversial. So you take a position on it. I think some churches are going to, if they're not buying into it, they might just try and avoid the conversation altogether. But I'm not thinking you're going to get away with it either.
No, and we need knowledge on how to deal with this. We need wisdom on how to engage with the community around us. But above all, I think we need the character of Christ when we do this, because we need humility and we need true love. But we also need to be able to stand on the basis of the truth of what we are saying. The best way to do that is to have a very acute awareness of your own sinfulness.
Yes.
Because we are not some special individuals. We are sinners that God has saved and reconciled to him. And it's just by his grace that we are not in another position. When we lose that position, we're gone. And we look like we're judgmental, and
yes.
We need to be able to stand on that position and understanding that. And I think therein is the true calling of the church. If we lose that, then it's tickets.
Yeah. So there's a twofold thing. We need to be informed on these issues. We need to understand the ideas. But whilst we're doing that, we need to also make sure that our hearts are also in the right place as we engage the culture around us with the gospel message. And it's going to be tough in these times for sure. But Reitze, look, thanks so much for your time this evening and for going along this session and the Q&A. I really appreciate it. And for all of those of you on watching this evening, thank you so much for listening in. And do please subscribe to our channel, and do feel free to recommend this YouTube to other Christians who might be interested, to churches, to pastors. If you want to get in touch with Reitze and hear more, maybe give me a call, contact me through Rasha Christie. Or you can go to our website. We have our information there. Send us an email. Maybe you want to invite Reitze or Zoom with him, and he can go into greater depth than he's done this evening on this issue. Put the stuff out there, and hopefully Reitze will have his job next week still, or something like that. We're not quite sure how that's going to pan out, but we'll see what big tech does with our YouTube videos. But yeah, there we go. Thank you so much. God bless to you all. Thanks, Reitze. Love to the family, and we'll see you next week. Take care.
Thanks, Simon. Thanks, guys. Bye bye.